Good afternoon. Let me thank Dr. Budway and Dr. Gupta and the rest of the organizing team for inviting me and for holding this wonderful conference. It has been a very robust discussion so far, and it's only the first day, and we are not through it yet. So I'm sure we'll see some more of this before the day is over and before the meeting is over. Also, I realized that I am standing between you and the tea break. So if you're nice to me, I'll try my best to let you go on time, But I haven't slept all night, I just arrived this morning, so heck, why not? So there's no question, I think, this panel has already alluded to both in terms of empirical observations about inequalities and implementation science approaches to addressing them, as well as some moral issues or imperatives that one has to take into consideration in addressing these inequalities. Particularly, it's interesting that we are talking about it in 2017, having faced it and studied it for several decades now. And of course, I think the main drivers of these inequalities have been very well identified in the literature on social determinants of health. I should confess that I don't like the term social determinants of health, essentially implying that somehow it's deterministic and not, it's immutable. If it is immutable, we might as well go home. But in fact, they are eminently addressable. My own preference is that these are social drivers of inequalities which need to be addressed, as we have seen in some examples that have been discussed today. But there are a number of them that have been well studied, and we know why these inequalities exist. So what I'm going to do, my talk will be in two parts. One is to give you a flavor of inequalities in India, not because you don't know them or that you're not aware of them, but to identify a couple of key issues, maybe 3 or 4 key issues for studying and where there are levers of change, and then end the presentation with an exemplar of a multi-level intervention of how we can really address these inequalities using that particular approach, I think, So there's no question, I think these data have been actually shared all day. People have been talking about it. So this is one example of a health equity or inequity profile in our country or in India. You won't be able to see it very clearly, but the point of this graph is essentially, a chart is essentially to see, on variety of important indicators such as reproductive health or maternal health or newborn and child health indicators, it is important to understand the dispersion as much as the bunching of the data, the mean itself. In fact, when you study disparity, standard deviation is more important, understanding that is more important than just looking at the mean. And I'll show you a couple of examples of why that becomes important as we discuss challenges in addressing them, I think. And I think the data are pretty clear and compelling on this kind of a dispersion, right? So if you take rates of delivery in institutions in India, again, the richest quintile have 6 times more than, more likely to deliver in institutions than compared to the poorest quintile. Again, that dispersion, right? The issue of out-of-pocket expenditure leading to all kinds of adverse conditions in terms of socioeconomic status has been well documented, with 40 million in India, facing poverty as a result of that, right? And the other point of dispersion is not just about wealth, but also variation across states. So there are states like Maharashtra, which have very good indicators or comparatively good indicators compared to a number of other states that do not necessarily have these indicators. So when you think about addressing disparities or developing appropriate interventions for them, again, trying to understand that kind of variation is very critical. Same thing with India. India, there is, several people have begun to allude to the issue of NCDs, non-communicable diseases, obesity is indeed becoming a problem in India. At the same time, more than 50 million children are still stunted with lifelong consequences that are faced by them, right? Or you take indicators like access to drinking water. Again, it varies tremendously state by state. Or if you take indicators such as, and this is a global indicator on access to internet, you can actually see, it varies tremendously again across countries, but also within countries. So in India, about 20% have access to internet, even though people don't believe this data, because we think everybody has a cell phone, everybody has an access to it. But unless you start looking at the empirical data, as we have done, where you look at access day in and day out, you will actually see these differences or inequalities among people. And you can, I can go on and on these data. Open defecation, again, the households reporting open defecation, in Assam, around 33%, all the way to 77% in certain, in Chhattisgarh, 74% in Chhattisgarh, and so on and so forth. If you look at cancer rates, because I want to give cancer as an example or an exemplar of a multi-level intervention. Again, there are fairly good data on what are the leading incidents of cancer or sites of cancer, both in men and women, and certainly breast and cervical stand out, but lung cancer and mouth cancer are also widely prevalent in India. At the same time, if you look at what leads, and cancer is, spread across a number of states, almost, with a burden. I think, especially tobacco-related cancers are singularly responsible for one of the heaviest burdens. And if you look at who uses tobacco in India, and I think a number of people from TMC have taken a leadership in it, including some advocacy organizations and foundations who are here today. Again, people who are in agricultural manual sectors are much more likely to use tobacco compared to people in non-manual sectors. If you look at wealth, it's the same trend. People in lowest quintile are much more likely to use tobacco compared to those who are in the highest quintile. The point I'm trying to say is that, when you look at these inequalities, we do have to look at these social drivers that really push towards these inequalities, so that we can then identify what kind of levers do we have to promote the change we want to change, we want to do. So what can be done? What should we do? I think the tendency is to focus or zero in on one sort of a intervention or policy and say, okay, let's do that, let's implement it, and that should take care of the problem we are trying to address. But we have, looked at the empirical evidence over a period of time. I have realized that, that what we see ultimately when it comes to the individual behavior, it's that individual behavior is actually driven by multiple levels of influence, all the way from government policies, laws, regulations, contracts, to community and social level, physical and cultural environment, healthcare systems, and social networks or interpersonal networks. All of them combine to influence individual lifestyles and behaviors. So when Dr. Anderson showed that the 30% of the cancers are caused by tobacco or 20% by obesity, at the end of the day, the decision to smoke or not to smoke, use tobacco or not to use tobacco, or eat or not to eat, or eat what, is particularly influenced by these kind of a multiple concatenating series of conditions, that drive these behaviors. So intervening at one level, as we sometimes or most often do, is unlikely to do much if we do not address interventions at other levels also. This is one of the reasons I think, most of the interventions we have two consequences. They seem to work, but they seem to work only for some sections of the population and at the cost of other sections of the population, or we declare that they haven't worked very well. I think this is one of the reasons why they don't seem to work very well. But it is not a lost cause. We have great examples from a variety of disease sectors or health areas, health problems. Tobacco is a very good example of that, right? Because Given that it's being hosted by TMC, I thought I would take tobacco, also because it's a big problem in India, right? If you look at tobacco and how we have developed this kind of a multi-level interventions, it's a great exemplar of how we can tackle the problem of tobacco using or addressing issues at a variety of levels, right? So, for starting with a global treaty, possibly the first public health treaty of its kind, the Framework Convention of Tobacco Control, which was mentioned today, clearly identifies a small set of conditions that could potentially have a tremendous impact on how tobacco use could be addressed at the individual level. It's an individual behavior, but is influenced by these conditions, right? So these small set of interventions are taxes, enforcements of policies on advertising, sales, and restrictions at the point of sale, health systems capacity building for cessation support, and influencing public opinion, including social norms, individual knowledge, attitude, and behaviors through public communications and public education strategies. Once we adopt these strategies, as many countries have done, we have made a considerable impact. We have had considerable success globally in stemming this tobacco epidemic that has been aggressively pushed by this, one of the most malevolent industries of its kind. Right, so there is not only no safe level of tobacco, but if you look at the aggressive tactics of the tobacco industry, I think taking this industry on requires this kind of a global, multi-sectoral, multi-level approach to address them. So this is what I mean by multi-sector approach. I'll come back and talk about it when I'm moderating this session. But this, if the ideal world, if there is a good collaboration among all sectors, all sort of this is a radial chart, all of them should be dark. But what it clearly shows is in one study we have done, there is very little collaboration across sectors. That's very important, I think, in addressing these problems. But these data clearly show that taxation does work, that taxes do protect the young and the poor. Some people have criticized it, particularly tobacco industry, that it's a regressive tax. That's because I think people are smoking or using tobacco less. But the fact of the matter is taxes do work. Advertising, promotion, and some sponsorship bans also work. Tobacco industry spends multiple levels of billions of dollars every year aggressively pushing this product all over the world, right? So we need to really come together to address this issue and do this kind of a counter-marketing strategies. Plus, we have to build capacity in the system among healthcare providers to provide cessation support. It is not cheap, and not everyone has access to nicotine replacement therapies. The question then is, in the absence of NRTs, what else can we do to promote cessation? But how do we help providers, not just doctors who are always busy and overworked, but everybody else within the system to have access to cessation resources so that patients can benefit from it. And then we have possibly one of the most rigorous, well-documented, extensive evidence bases or database to show that mass media campaigns can be extraordinarily successful in changing social norms and changing attitudes and behaviors. If you do not change norms and knowledge, then people will have this kind of an opinion. When you ask people, why is it that some people are able to quit tobacco more than other people, their argument is people lack the willpower, which is far from the truth. We know that tobacco use is an addiction. It requires a particular empirically based approach. But if you don't tell people that it can be addressed, it's not because people lack willpower, then these are the kind of opinions that are likely to prevail. And therefore but this is mutable. We can address them through our campaigns and we have fairly good evidence. In the same way, we can influence each other, right? Social networks are extremely important and powerful. This is one good example. This has nothing to do with tobacco, but this is a good example of how obesity, individual thing, obesity spread within social networks. These are Framingham data by a former colleague of mine, Nick Christakis and his Fowler, where they looked at how interpersonal social influence has led to lifestyle changes and behaviors which led to increase in obesity. So what it suggests is the importance of social networks, our friends, our referent groups, our family members who can potentially be very influential in addressing these problems. There is one issue we can change norms very successfully with mass media campaigns. The biggest challenge in doing this is that if we do not take into consideration potential chances of exacerbating those inequalities, mass media campaigns can lead to those inequities, I think. So we have to take that into consideration. And this is a good example, the Truth campaign, that has actually led to a tremendous success in stopping 400,000 youth from picking up tobacco use habit, right? Warning labels are another good example where we have whatever I have done, maybe I'm still sleepy, so warning labels are an excellent, another good example. Can you get it up? Okay, so, and these have been very effective. So we were very worried about it when these started, well, they have an impact. What we have done is now globally there are a number of studies that clearly show that people who have seen these labels, are, for example, if engendered negative emotions, they are 6.9 times are more likely to express quit intentions compared to other people. And the best thing about it is we found, and others have found, that warning labels do not increase inequities across the system, right? So it's a blunt instrument. Policy is a blunt instrument, but if we do it carefully and thoughtfully, it is unlikely to increase, inequities. So I think there are ways of doing this in a multi-level approach, but it requires a different mindset which will allow us to address these inequities and not open up these inequities in the first place itself. Thank you.